surgery which is going to start a revision rhinoplasty here. Okay, you can see the scar here on this side. You can see the scar, that's from the earlier surgery. There's a slight deviation in the dorsal aesthetic line which we're going to fix. It's also pretty broad for her here. So we're going to narrow the dorsum. We're going to narrow a little bit on the alar base. She's not happy with these grooving, nasolabial grooving. We're going to get that down a bit. Nothing much on the radix. Little bit on the tip, nothing much. Thick skin. We've reduced the alar width. She didn't want much done on the tip. I've corrected the dorsal aesthetic line. That's the view from beneath now. So the nose was very bulbous. And you can also see the nasolabial grooving, the dorsal aesthetic lines. We've improved all of that. Subtle improvement in her case. It's not many millimeters. I often like to say that rhinoplasty is a surgery of millimeters. And just that we've done for her. Couple of millimeters here and couple of millimeters there, and we've got this kind of subtle improvement. We're also going to show you the basal view now. Scar at the columella. So taking care of both of that. It's a close up to show you the difference that we have done. So I'm going to be applying some steri strips now for this patient. And what you see is a revision rhinoplasty. The revision rhinoplasty is always challenging because not only do you have to look at what the surgeon has not done precisely, sometimes it's not the problem of the earlier surgeon at all. It's very often also the concerns the patient has. Either the patient's concerns have changed or they weren't addressed clearly to the earlier surgeon. So the results that we've got is not probably what the patient has wanted. So now in this patient we had to improve the dorsal aesthetic line. You can see I've made it a little bit more sharper. Also we had to fix various issues on the inside of the nose that had to basically do with the asymmetry on the basal view. We're going to show you that as well. Steri strips. Didn't do any septal work for this patient. It wasn't needed. She had good septal support and also no issues with breathing. We did do osteotomy. That's the puncture mark. And the scar that you see is because of the blepharoplasty that we did yesterday for her. This was a lower lid blepharoplasty with a mid-face pexy to tighten the area and to reduce the grooving. So we did that under local anesthesia. This was done yesterday so that we didn't have any issues with the nose. Okay, now we're going to place the pack. So we're going to put a software tool pack for this patient. You see we've cut a software tool into two and we're just pushing this pack in. When we do a lot of septal work, then I put a more extensive, bigger pack, but this is going to be enough for this patient. And you can also see work was done on the tip and mainly on the alar base and around to correct the asymmetry that she had. Now we're going to put one more steri strip. And this is to keep the nose together. And then we'll put a splint on top, which is a thermo setting splint, meaning we put it in hot water and then that sets quicker, better, and gets rigid. And then I'm going to put a stitch here. So this is to make sure the steri strip stays in place. These are pretty much standard techniques for all patients. Some variations can be there, but usually I do these for almost all patients that undergo rhinoplasty. Then we're going to show the splint now. So we've got the splint here ready. We're going to cut this down to get the shape. So we can measure it actually. So this is the extent that we need. Then we will put this in hot water, which is what I'm doing now. You can see me dipping. Then we take a gauze, a mop. We will wrap this around just for a while, just to take off the moisture, make it dry. When that's done, then we have to adapt it. So I did mention to you that we did an osteotomy for this patient, so I would need to adapt it in such a way that the nasal base that we've osteotomized and moved inside stays that way. This is kept for about a week, sometimes a little bit longer. So you can see that splint getting adapted nicely. Once we're done with this, the last step is to stabilize the splint. So we use Rhinoplast or elastoplast, and we can just tape it down, a couple of them usually. So we're done. So that was a steady strip put by our anesthesiology team for anesthesia. Just gonna make sure this is fine and tight. It is. So there's no ooze. All right. Thank you.